So hi, everyone. Welcome to our third webinar in the ONTPD webinar series, How to Build a POCUS program. Today's program will primarily focus on credentialing, billing, and coding. And we are very fortunate to have Dr. Alan Gross as our primary speaker today. Dr. Gross is an attending neonatologist at UT Dell Children's Hospital and associate professor in the Department of Pediatrics at Dell Medical School. He has been a leader in neonatal point of care ultrasound field, and he has implemented POCUS techniques and targeted neonatal echocardiography at several institutions now. He has even created a POCUS focused website, NICU POCUS, which is really dedicated to ultrasound training within the NICU environment itself. So thank you so much for being here today and speaking with us. I'll hand it over to you.
Thanks, Carabeth. I really appreciate that. It's nice to be here. I'm really enjoying this series of webinars. I have implemented POCUS. This is my third go round here at Dell in Austin at getting POCUS up and running in a different institution, and I've made a lot of mistakes along the way and hopefully learned from some of those mistakes. So we're going to talk a little bit about that experience. As you mentioned, I'm not disclosing my website or my Twitter feed because it's a conflict of interest. I don't make any money from the website. I don't advertise on the website. I don't know how to track people's mouse clicks on the website to get more information about them. We just started building it about 12 years ago to put together some learning resources, and we're still building it, and there's a lot more needed, but there's a fair bit on there if it's helpful for people to have a look at. As you mentioned, this is the third in the series. I've just shown the screenshots of the other two. Those I'm sure are on one of our ONTPD or training websites, but you can also just find them on YouTube. They're very easy to find. If you just look up ONTPD POCUS, you'll get straight to those. And one more to come after this about quality assurance. But previously, Mackie has talked about developing the program, and Stephanie talked about the curriculum. So I'm going to talk a little bit about the risks and benefits, because I have found this process useful when I'm discussing it with my administration, with the people that buy the equipment, with the people that run our quality assurance, who look at risk, your CMO, your chief of service, whoever else it might be. I think it's helpful to make sure we can make a structured argument for POCUS. We're going to talk a little bit about credentialing and privileging. We're going to talk not very much about billing and coding. We're going to make sure we leave plenty of time at the end for the panel discussion. I would accept that this seesaw of risk benefit for POCUS is where we were 5 or 10 years ago. I think in particular, if people have ambitions of complex hemodynamic management, that some of these concerns are still valid for misdiagnosis and things. But I don't really believe this is where we are currently with point of care ultrasound in the NICU. I don't think any of these 4 things are unmanageable. And I think it's clearer and clearer that we have a growing list of indications, that the imaging is getting better and better, that the simulation training is getting better and better, the digital connectivity for the image retention and sharing is getting better and better. Everything is tipping in POCUS's favor. The rest of the world is a bit further ahead than the US on that, but we're catching up fast, thanks in great part to a lot of the people that are on this group who are really driving the process forward in the US. And what I want to talk about today is a structured implementation approach to POCUS that I think clearly then tips the process in the favor of POCUS by minimizing the risks that are on the left-hand side of the graph there. I really think that we can drop those down to as small as possible. I wish that we could make this process very easy for you by simply saying, here's the standard national credentialing process for point of care ultrasound in the NICU. It is not for a want of trying. We've been talking about it for many years. It's hard to come up with a one-size-fits-all solution for POCUS that covers the range of skill sets, of clinical indications, of training, of equipment, of quality assurance, of image archiving, and in particular the local landscape of what your hospital's needs are and what your hospital's barriers are. We're still working on that process, and Cara Beth, you've met already, is part of the group that's driving Patrick and the ONTPD team to make a national fellowship curriculum for this. And we hope that will come out soon, and we'll be there for a clear roadmap for credentialing for fellows. And otherwise, I think for where we are today, presuming one wants to start today or keep growing your program today, there is actually all the components of the roadmap are there, all the bits of guidance are there. So there's plenty of guidance, the curriculum I mentioned, and there are lots of centers that you can speak to share experience with credentialing and practice, both NICUs that are geographically disparate from you and your other units that are close by, that are CICUs and PICUs and emergency departments. This for me was a huge piece of the jigsaw. Kudos to Maki Fraga, Yasser Al-Sayed, both great neonatologists who pushed this through. This is a pair of statements from the AAP, Committee on the Fetus and Newborn, that came out as both a clinical report and a technical report as a pair of publications, I think in November or December. They have gone a huge way to standardizing the indications, the process of doing the scan, and we've talked about those in the last two webinars, so I'm not going to spend time running through each of the indications, but I have to mention them briefly to try and guide what my suggestion is for the process of how you consider which elements of a POCUS program to start with in your own institution. One of the things I particularly like about these statements is that I think they're embracing that concept that we have to do POCUS now. As much as it's our responsibility to understand the limitations and challenges, it's also our responsibility to make sure we keep up to date with advances, and we make sure that our patients are benefiting from the safest, most efficient state-of-the-art care, and POCUS is part of that. And I think anybody that's using POCUS is not in doubt about that. I don't know anybody that started using POCUS and said, no, screw it, this doesn't work. It really works. The key elements of the AAP guidance, just as a brief refresher, you should probably have a hospital-wide POCUS committee. You should have a medical director for POCUS within your NICU. You should have radiology and cardiology buy-in. You should define a scope of practice and indications. You should standardize your training, clarify your privileges, credentialing, make sure you've got image archiving set up, make sure you've got QA. And once you've done that loop once, as with all good QA, you go back and add something into your program and keep assessing. This then is the technical report, the second of that pair of papers. Cara Beth, would you remind me at the end to clarify whether or not those are something that we can put in our shared folder, or if that breaks any distribution rules for the papers? But this technical report goes into more information about the way in which the scans would be done. And broadly speaking, the AAP has decided to break our NICU POCUS indications into diagnostic and procedural. That's fairly well standardized now across different clinical areas. And the diagnostic, lung, heart, abdomen, head, and this EFAS type approach to the decompensating neonate, which looks very interesting. And then the procedural stuff, vascular access, lumbar puncture, draining anything from anywhere, and intubation in ET position also looks quite promising. One of the key things from that paper, and also from, this is the equivalent document from ESPNIC, the European Society of Pediatric and Neonatal Intensive Care, talking about POCUS in both the NICU and the PICU, is an acknowledgement that not all POCUS applications are created equal. Some are easier than others, some are more risky than others, and broadly speaking, ESPNIC suggests having these three tiers of performance of point-of-care ultrasound, where some are more evolved and require more training in QA, and some are less evolved and easier to get people started with. But again, this doesn't suggest that there's a one-size-fits-all. What I want to talk through in this session over the next 10 or 15 minutes is my suggestion for how you go from not doing POCUS or doing a limited amount of POCUS to decide where you expand next, which is the right indication for you. And I'm actually basing the sequence of my slides on this wonderful article from Jay Kim. He talks exactly about this 5-step process of looking at POCUS, deciding what you want to do, look at what your strengths and your weaknesses are, set up didactic and simulation-based training, pick 1 or 2 applications that you think will be the best fit for you. And then once those are working, show everybody how well they're working, celebrate the successes, and expand it to whatever's next on your hit list. And having tried to set up POCUS programs twice, where I tried to set up far too many things for far too many people, this is what I'm doing at Dell Children's in Austin at the minute. We're absolutely focusing on vascular access, and it's much more conceivable to get up and running in that way than to try and train everybody for everything. So broadly speaking, this is my suggestion for how you do your needs assessment. Have a look at what your pain points are. Have a look at the expertise in your team. Have a look at the expertise in other teams within your institution. Often the PDD guys are way ahead of us. The PICU guys are often way ahead of us, but also radiology, cardiology. How much time do you have? Pick an implementation that's feasible and completable. It's a bit like getting your fellows to pick their research project. You're not going to set them off on something that they won't be able to finish. It's a bad idea to set off on a POCUS implementation that's going to take you 1,000 personnel hours of proctoring when you only have 1 or 2 people that can do those supervised scans. What hardware have you got, or what hardware could you get, and what simulation kit do you have, or what simulation kit could you get? There's lots to read on this. This is Shazia Bombal's and her team's experience from Stanford about their implementation. Really wonderful description of how they did it and what they ended up finding to be useful. Same for Dalibor Karepa's group here at Northwell in New York, where they again looked at a structured program. And again, I'm not saying you should precisely follow any of these templates. My suggestion is that you do that kind of needs assessment and work out where to start. This is where I went wrong at Mount Sinai. Admittedly, COVID didn't help, but when I got to Mount Sinai, I was super excited about POCUS, and I decided that we would have a foundational training package here across the base that everybody would do for general principles, and anybody that wanted to learn PICC line and UVC would do these modules, and bladder scanning for urinary retention these, and lung scanning these, and hemodynamics these. And the problem with that process is that if everybody wants to train to do everything, if you've got 40 nurse practitioners and attendings and they each need to do 100 scans, then suddenly it's very, very hard to be around to be helping out with all those different scans. In Austin, I made some of the same mistakes, but I've pivoted a bit more quickly. We were super excited about this approach that Ben Kozyak and his team from CHOP wrote up about salvaging UVCs that have gotten stuck in the liver. It's a great indication for point of care ultrasound. And if you've got the right institutional support for it, it's a really, really wonderful place to start. But it's not a terribly easy or terribly intuitive imaging plane to see the UVC coming down here and through your portal sinus and round into the ductus venosus. Once you've been shown it a few times, I think it lands, but it's not the very simplest thing to do, but it is very rewarding to do it. So what we've done here at Dell is go through this process and essentially say our biggest pain point has been and remains vascular access. That's whether it's a PIV being done by our nursing staff, or PILs being done by our attendings, or PICC lines being done by our transport team or our PICC team. Everybody finds vascular access in newborn babies challenging, and the more complex your case mix, I think in general, the more challenging it is. We didn't particularly have NICU expertise in using POCUS for vessel finding. I've done a lot of cardiac and hemodynamic stuff, but finding these tiny vessels in babies was new to me. But we were very lucky that we were able to look around and find somebody in the institution that did do that. Amanda McKinney had done this process at Texas Children's. She'd shown her ability to roll that out to the different resource or charge nurses at Texas Children's. And we decided, therefore, that the first thing we would do was offer these sessions for our resource nurses, for them to do proctored scans. And then hot on the heels of that, we're running out a slightly broader training program for our attendings fellows, and nurse practitioners. But again, all access focused. To make sure we're doing that within safe limits, we have written a set of standard operating procedures for neonatal care that have gone through our formal guidelines committee. So that document is in the POCUS shared drive. You're all welcome to take it and copy and paste the bits that are valuable. Similarly, we've done a separate document for specific to vascular access that is in there. The hardware, we've been using one of these devices for a couple of years. I quite like this device, the Philips Lumify. Here is my left radial artery. It's a 3mm blood vessel. And if you just stay in this left-hand image for a second, you can see that there's an artery in the middle. And these Mickey Mouse ears on either side are the little venules that course along beside your artery. So all those times that you tried to do a PIL and you thought you'd maybe just nicked a vein, well, it's not surprising. The artery has a bodyguard on either side of a vein that's very easy to hit. And you can see this pretty well with a device like this. The Philips Lumify is about $7,000. The GE Vscan Air is about $5,000. And for a decent sized vessel, very easy to see. Once the vessels get smaller, here's a 1mm artery in my little finger, and it becomes much harder to see that. So while you can do these with these very cheap entry point handheld machines, if you can persuade somebody to buy you a fancier machine, the benefits in the imaging really pay off. So here's our current imaging with the GE Venue Go system with a 22 meg linear probe. Here now is my same left radial artery, super crisp. Here's that same artery in my pinky. And I think this video will play in the middle just to show you that I'm not making that up. This is me scanning the artery on the inside aspect of my left little finger. And you can just about make out that same artery there. It's a 1mm vessel, but a 1mm vessel is pretty much the size of vessel you're going for if you're doing peripheral access in the NICU. Again, not the role of this session to teach you how to do that. The role of this session is to help you sort of set up how one might do that if that's where you decided to go. Many simulation teams already have this very elegant 2mm blood vessel task trainer that you can get in the US online for $500 or $600. There's another device which is currently only available in Europe, but they will ship it to the US if you pay for the shipping, that has a 1mm vessel in it. Training people on these simulators, and then if everybody's happy to do it on each other's small vessels, is a fantastic way to get people ready to do PIVs and PALs and PICC lines, because you get the hand-eye coordination of putting those lines in. What other bits of training can you put together relatively simply? I'll show you our credentialing and privileging document in just a second, but one of the things we said was reasonable was to have 12 hours of training as well as a set number of procedures. Those 12 hours can, of course, all be in-person didactics and simulated training and so on, but there's lots of online resources that are excellent for that. So at the minute, we get our team to do this for our POCUS fundamentals certificate that costs about $120. We also get them to take this Med Mastery Procedural Ultrasound Masterclass, which you can do for about $45 for 1 month, or you can also buy a group license at a decent discount, which is what we're doing at the minute, where you can swap people in and out of each of the license slots. So we've bought 15 licenses, but actually we can get 50 people through with those 15 licenses, because once somebody's done their training, you take them out of that training seat and put somebody else in it. So lots of these processes absolutely POCUS targeted. Of course, no substitute to actually doing the procedure oneself, but a really good baseline of training. What else do we suggest having in your process? I think everybody agrees that we should be tracking the number of scans that we've performed. We've chosen to do that with REDCap. Again, many institutions now are using REDCap or have some expertise with it. So we have a very straightforward provider training log that is a QR code that's dotted around the NICU. And every time somebody does a scan, they just have to click on that code. And there's, I think, 5 or 6 drop-down boxes to make sure that that activity is logged. It takes 15 or 20 seconds to go through that process. So it's a bit of a hassle, but it's probably better than having a piece of paper that you fill out and then lose or spill coffee on. The data dictionary, for those of you who are REDCap savvy, you can import a data dictionary into REDCap to set up this kind of survey. And again, we've dropped that in the shared folder for you guys. So all you would need to do is change your indications if you want to, and change the name of your personnel, and you're off and running with a simple to use REDCap database. This is one point of the process that I'm somewhat in equipoise about doing, but overall, I think it's worth discussing. This is a demonstration of proficiency where we make sure that at the end of doing however many scans you feel is necessary, everybody just kind of make sure they just stop and take a breath and say, all right, let's just do one last scan and make sure I'm really focused with you the whole way through. Do it from start to finish. Talk me through everything that you're doing. And in education world, that's called a mini KEX. And this is my suggested checklist to go through that process to make sure that somebody has truly done their point of care ultrasound scan from start to finish. And therefore, the final part of credentialing sign off for us at Dell is that you do that last scan with me or one of the other handful of experienced ultrasound people who will make sure that we've just got everything nailed down. We sign you off on that, and then you're done. Karina pointed out to me, Karina Lawrence, who's on the panel at the end. Thank you, Karina, and she'll go into this in a little bit more depth. Pointed out to me that many of us use the terms credentialing and privileging interchangeably when they're not quite the same thing. That credentialing is more about demonstrating one's previous competence, and privileging is saying what one is allowed to use that competence for. So I'm sorry, I should have changed this to a privileging form rather than a credentialing form. But this is what we're currently using in Austin. This is our list of our indications down the left-hand side, very granular so that people can choose to be signed off for some of these, but not others. I am currently privileged to do each of these things: PIVs, PALs, UVCs, UALs, PICS, assessment of urinary retention or oliguria, a limited cardiac assessment. Is there heart beating in a code? Is there a pericardial effusion? And broadly speaking, do I think this baby would benefit from volume expansion? And then pulmonary in our hands, we have currently limited our practice just to presence or absence of pleural effusion because we don't have somebody on our team at the minute that could really drive the elegant assessments of lung recruitment or pneumothorax that are absolutely available. That might be your place to start if that's the better fit for your team and your skill set. We've said for our team starting off that they should have 12 hours of didactic training and a minimum of 25 scans. And that 25 scans is allowed to include a range of these things. But of course, we have our mini KEX in place. So if somebody's done 24 PIVs and 1 cardiac ultrasound, I will know that from their tracking REDCap database, and I am not going to sign somebody off to do cardiacs if they've only ever done 1. What I didn't want to do is have 25 for each of these things, because I don't think you need 25 to look for a PIV or to check for a bladder. So we reached this compromise. This is where things like the national credentialing process get really bogged down in determining exactly what those numbers should be. And this is what we got through our guidelines committee, what we got through our credentialing committee, and I'm happy enough with it, so long as people stick with the spirit of the ruling as opposed to the exact wording of the ruling. Yes, you could short circuit this to be credentialed on something in which you have minimal experience, but because we have that final step in place, and we'll talk more about QA in the next webinar, I think we've got the right checks and balances for me to balance not putting up such obstructions to POCUS credentialing that nobody ever gets there, versus having some measures in place, some guardrails in place to keep people safe. I'm going to skip on from that. Oh, I'm talking quickly, aren't I? I want to talk a little bit about billing, and again, lots of time for discussion at the end. Please don't go into a point of care ultrasound thinking it's a moneymaker. I think please do, if you're doing something that genuinely improves patient care, it's pretty reasonable to be reimbursed for it. I think that's okay. But it's not going to make anybody a fortune. This paper here from Christopher Moore is an excellent summary of credentialing reimbursement for POCUS, even though it's 12 years old now. Many of the manufacturers have their own guidance. This GE leaflet is excellent. Sonosite have a whole series of leaflets about each of the different indications. Their vascular access one is great. Their emergency medicine one and their intensive care one are probably the only three you need. And the Society of Point of Care Ultrasound, as you would imagine, has got a really great description and again, a very in-depth discussion about what one really needs to do for billing and reimbursement. As I said, it's not a big moneymaker. The actual money reimbursed for these is for individual scans is really quite small. Key is for, well, one concern that always comes up is ultrasound bundled? And the answer is a complex two-part answer. Ultrasound is not bundled in your critical day intensive care or critical care codes in the NICU, which is good news. But many procedures are bundled, and POCUS guidance for that procedure is therefore also considered bundled. Slightly fudged answer, but that's my understanding of it. And David Cantor, who sits on the AP Billing and Coding Committee, has reinforced that message for us. And we feel if that's not the case and anybody ends up in prison for it, I'm really sorry, but I promise you that is my understanding and what I've been doing for the last 4 or 5 years, and nobody's come up with a criticism for that yet. Billing does, of course, require some additional things. The documentation of the scan and its findings, we'll talk about that more in a second, and the archiving of the images, we'll talk about that more in a second as well. I've just thrown a few example CPT codes in here so that one can just dig into that and have a look at those. I've put some example numbers on here and some of the modifiers on the billing. So those of you that have done some billing in the past will know that you have a code for whatever it is you do, but you often also have a modifier. So if I do a limited assessment of a baby's cardiac function during a code where I think they might have a pericardial effusion, I can bill that as a 93308. I get to bill the professional component of that, and that nets my organization at Medicaid reimbursement a whole $25. The hospital, so long as you've got something set up nicely with your hospital where they know what to look for, can also bill for the technical code for that. And it's really nice to be able to show willing, I think, to your hospital administration. Again, not that you're going to make them a ton of money with POCUS, but a few of these scans over the year add up, and the machinery is getting cheaper and cheaper. You can certainly offer to contribute to the expense of the machines that you're buying by making sure that the hospital component of this is reimbursed. A few things that are not billable, just checking to see where a PIC position is by ultrasound and not adjusting it, not billable. Any bundled procedure, as I said in the last scan, not billable. Anything to do with a UVC or a UAC, not billable, unless you think your UVC is giving you a pericardial tamponade, in which case it's a 93308. And then this, I think, is the most gray of our bits of billing advice. But again, David Cantor's opinion is the one I trust most on this. And this is his exact wording. If you're doing a brief targeted assessment of cardiac activity, he considers that to be a vital sign, and therefore it's bundled, not a limited echocardiogram that is unbundled. Now, obviously, we could go back and forth on that forever, and I use what I call my Auntie Carol test. My Auntie Carol is my godmother. She's the person whose opinion I am most wary of, and I like to run the test myself to say, would Auntie Carol approve of what I'm doing here? or would she think I'm trying to get money for something that isn't truly adding value? So I make sure that if I'm doing something that truly implements care, that my Auntie Carol would approve, and I write the note to back that up. Modifiers just talked about briefly. 26, if you're just doing the professional component, the hospital can then bill the same code with a TC for the technical component. Many POCUS scans are actually already intrinsically limited scans. So the 93308, for example, that I said is by definition a limited scan. But if you're not doing something that has a limited scan on it, and you do a limited scan, for example, abdominal ultrasound, but you only look at a part of the abdomen, or there's lots of artifact in the way, you should put a 52 modifier on there to say that you didn't do the complete examination. Lots of variability among payers of how these things are reimbursed and how many of these things are reimbursed. As a rule of thumb, if you're doing any of these things multiple times a day, it becomes a bit harder to justify. I'm not saying one shouldn't do that. I certainly do multiple images sometimes. I had a kid last week that we had to keep reassessing for markers of cardiovascular collapse multiple times through the night. Actually, I only billed for one. I could probably have billed for more, but I'm going to stay on the side of underbilling rather than overbilling. Documentation, fairly well agreed. I understand that the next session is going to go into a bit more into documentation as well as QA, but I had this slide ready. Sensible to include the indication, the technique, the type of study, the findings, your overall impression, make sure your name's on there, and crucially where your images have gone to. I don't think it matters whether that's a procedure note or an event note or anything else. I think it just matters that there is a note. And then last couple of slides for me before we get to the discussion, image archiving. I wish I could tell you that this is what we are doing in Austin, and it's not what we're doing in Austin. We've been working with our IT team and our finance team for over 3 years to try and get a fully integrated POCUS workflow. I know some other centers have, and I welcome them jumping in the discussion phase to talk about their impressions with QPath or Viewpoint or some of the other vendors that are out there. What I'm working towards here in Austin is what I think is the correct optimal workflow, that you recognize the need for a point of care ultrasound scan, you place the order for that in your EHR, Epic, Compass, whatever you're using, Cerner, you pick up the scan on the machine in the work list, you do the scan, the images automatically get sent back to the EHR and they're linked to the patient, and the report can either or both be written on the machine or in your EHR, and it's all linked together nicely, and the billing happens automatically as part of that process. It's possible to get there. Other centers can talk about it in the Q&A, but it's not a simple implementation. There are, however, multiple other ways that one can do it in the short term, and in the last 10 or 15 years I've done each of these three in different combinations. So currently in Dell we are sending our images to PACS, and that means that they are stored in perpetuity and findable. Are they linked to the patient's EHR? Well, they are, so long as we've put the MRN in correctly. But if we put the MRN in incorrectly, then no, they're not. And that cannot be 100% effective for the babies that you do this during a code. I bet we make some point errors. But overall, it's still enough to justify billing, and it's certainly plenty to be able to do quality assurance, which are the two main reasons I think for having the images archived. If you have a friendly cardiologist, they will often let you jump onto whatever they're using for their echoes. This is what I was able to do at Sinai, and our cardiologists were delighted to do that for us, because the total number and storage capacity of our scans was less than 0.1% of the storage that the cardiologists required for their echoes. So it really made no difference to them if our images were there. And things like Merge Cardio will easily let you set up a subfolder for your NICU POCUS images within Merge Cardio or Singo or Ambra. Same for PACS. If you're really stuck, rather than leaving your images on the machine itself, which can get lost or dripped on or can just crash, you can just take the images off and put them into one of your standard hospital servers. But at that point, they're clearly not easy to find, and they're clearly not linked to the medical record. I would be cautious about billing if I was using that approach, but it would be better to be doing that, as I say, than doing nothing. I think it's a good idea to have a barcode scanner for your patient ID. I think that just helps with the workflow and takes out the scope for data point entry errors. And your IT team may insist that every user has their own login ID for the machine. And if they do that, then you probably want to set up to have your ID badge unlock the machine for them, rather than everybody having to remember their own password and update it 3 months along with all their other passwords. Once you're in there, your friendly ultrasound rep, my GE people did this for my GE people, I don't own them, did this for us last week. Very easy to get in with your admin settings and set up where you want your archive to be, your pack storage, how you want the images sent out. Super easy to do that once you know how. The trick is getting a friendly person in your institution's IT department to give you the correct destination to send the images to. But once you have that, it takes 20 seconds to set it up. I've gone over time, as I always do. My suggestions: think carefully about where to start. Start small and grow rather than getting everybody to do everything. Set up your own local guidelines until we've got national credentialing. Ask other people for help, your colleagues, your neighbors, your other departments, and people that are miles away from you. Lots of scope for training with simulators and online. Try and persuade the hospital to get you the hardware that you need and offer to get them some billing reimbursement for that. And make sure you're archiving your scans so that you can bill and do a QA. Quick plug for our related workshop at PAS, which is, oh my goodness, only 3 or 4 weeks away, on the Monday morning at PAS. Many of the people from this program also talking about how to set up a POCUS program. I think spaces are limited. And for today's stuff, we really do appreciate getting feedback on these sessions. We really want to make sure that we give you what you need. So please click on the QR code and fill out with some constructive criticism or on what else we can be helping you with. So I'm going to hand it back to Cara Beth. Thank you so much.
Great. Thank you so much. That was really amazing. I think that gave us all a lot to think about. So now we are going to transition to our expert panel Q&A portion. During this period, please feel free to send any questions you have to myself, Karina Lawrence, Rachel Weinstein, and we will make sure that they get to the expert panel. So we are going to start off for you guys with a question on billing and coding. How did you start billing and coding for POCUS scans at your institution? Were you collaborating with other divisions at like PIM? Alan, do you want to start us off with that maybe? How exactly, or how have you heard other people start off?
I feel somebody else should answer rather than me talking anymore.
Well, Jason, I know that you guys do a lot of billing and coding over at CHOP. Do you want to chime in with what your experience has been?
Actually, we don't. Our hospital sort of does it in the background. So unfortunately, I'm not the best person to ask for that. I know they bill, you know, a little bit. We don't actually see that money. You know, maybe our boss sees it. We do all the things Alan mentioned. We document everything. We upload all our images to our PAC system. The credentialed people in our division write a note for each procedure. Sorry, not each procedure, each study. And so I think we give them all the tools in order to bill for it, but I think behind the scenes they do it. So I'm thankful for that, but it makes me a little bit ignorant. So sorry.
I think maybe our institution is somewhere in the middle in terms of its process of trying to get the billing up and running. So our CPT codes are built into our documentation, which is nice for our ultrasound guided central lines. And then honestly, it kind of just goes into the ether because I think we are still trying to work out that entire process. And I really, Alan, I really liked your slides on the billing. That first slide that you gave with the CPT codes, I thought was super helpful. And going through the fact that it is not considered as part of your bundled billing, I think, like you said, is a huge thing for a lot of folks that are trying to get their POCUS programs up and running. Because not going to lie, I thought it really was still all, for some of that stuff, still all tangled in with the bundled billing. So
Yeah,
that
we
was
estimated, and we hit pretty close to this, I think, at Sinai, that once a decent number of us were doing it, the reimbursements were about 10,000 per year. But by lucky chance, 10,000 per year is enough to either buy you a new handheld every year or to lease a $50,000 machine over 5 years. It's probably cost neutral to do POCUS in the strict money terms. Of course, it saves you huge amounts of time. So it's vastly cost beneficial if you're being sensible about it. But I say the value for me is that if I have a UVC that's stuck in the liver, I can get it into the right position in the heart in 3 to 5 minutes, or decide that it's not going to work. What I don't do is stand there for 90 minutes getting x-ray to come back, reposition, fiddle with it, and shoot it again. So it's huge value, not necessarily huge reimbursement.
Yeah. And to kind of get to that tail end of the question that you asked, Cara Beth, on did you partner with other divisions like PEM to get your coding billing up and running? I think we partnered with PEM and also PICU for most everything that we did, including the documentation. We actually have a shared documentation that has the CPT coding in it for our central access using ultrasound. So definitely a thumbs up to that process in terms of partnering, and like, why reinvent the wheel, right?
Yeah, absolutely. Well, let's transition a little bit to credentialing. So we've gotten a few questions about that. Do you guys have a credentialing committee for POCUS at your institutions that need to approve the proposed criteria, or how do you decide on the criteria and then the whole credentialing process?
So Dell Children's, we went through our evidence-based guidelines committee. We wrote a standard operating procedure for overall POCUS. We wrote them then for each individual application, and we made our suggestion of what we thought the credentialing should be. Again, we were hitchhiking on our pediatric emergency medicine team. I'd be surprised actually if anybody in this calls pediatric emergency medicine team aren't already credentialed to be doing POCUS.
Yeah, for us,
okay.
We didn't have, and I just will talk about their credentialing because they haven't established one. We didn't at Stanford have a credentialing committee. There wasn't a standard that we had to do that. We just did it internally and used similar numbers to what CHOP had used and what Alan has mentioned as well, with 25 in some of the fields, bladder with 10, but we did that internally. So that if people were interpreting images, that we had some quality on that ability for people that were doing the ultrasounds themselves.
Yeah, CHOP, we have a hospital-wide credentialing committee that had already reviewed and approved a process for different departments like pediatric emergency medicine and the PICU. But Maki and I went to them and presented our sort of proposals, and they were approved. And basically, everyone who wants to be credentialed in neonatology at CHOP has to do a 2-day course, similar to ones that are given in various places. Like we give a course, a CCM gives a course. There are many courses now around, but we require everyone to do that. And then we divide things kind of similar to what Alan said, is we divide them into procedural and diagnostic. Procedural, I think of it as not so much a separate credentialing process, but already you're credentialed to do PICC lines and A lines and IVs and, in rare situation, of pericardiocentesis. And for us, we just proposed that the ultrasound is a different tool to achieve that same procedure, right? You're not credentialed to use a transilluminator. So, how is ultrasound that much different? And then for diagnostic studies, it's much more relevant to the credentialing process, but we divided ours into different categories. For lung, you had to have 25 reviewed studies by someone, somebody else. Cardiac, 25. Each different category you had to have 25, and you didn't have to have all of those together. You can be credentialed to just do thoracic stuff, or you can just be credentialed to do, neonatal cardiac assessment. And so, that's how ours goes. But it's pretty streamlined, and then your division chief has to sign off to it, and then it goes to the committee, and then yearly. I think we didn't say you have to have 25 per year. I forget the number exactly, but you have to demonstrate continued commitment to keeping your skills up year after year in order to maintain that credentialing.
Great, thank you. We have had a question about the opportunities for credentialing at an institution where no one in the NICU has started using POCUS, and also what about if no one in the institution is using POCUS? What are the opportunities or recommendations that you guys have for people who are really like just getting started?
I would stick with a mix of the start small and grow. And I actually really appreciate Jason's verbiage there on the procedural stuff. Some of the barrier to this is just getting the machine in people's hands and making them start to get comfortable with it. So that feels like a PIVs, PILs, and PICs feels like a very sensible starting point for me.
I would be pretty surprised if there wasn't anyone within the institution that doesn't have some sort of POCUS. That just from a standard of care at this point, the PICU uses ultrasound for their line placements. And so having at least someone there to be able to help you with your initial starting is useful. We certainly utilized PICU and EM when we started off our programs for some of our image acquisition and interpretation. So I'd be surprised if there isn't someone using POCUS within there, even if you ask anesthesia or radiology. Generally, someone is going to be available that will be able to help you. And reaching out is certainly helpful, both for information and for machine access if you need that as well.
Yeah, anesthesia is a great suggestion. And if you're currently getting them to come up and help you out whenever you're stuck with access, that's going to make it more likely that they're going to offer to come and help do some training so that we don't bug them whenever we're stuck.
Yeah. I mean, other groups that you might not have thought of also is like the adult emergency department. Sometimes they might not be in the same building as you, but they definitely have people who are trained to do ultrasound, and oftentimes they never see pediatric cases, so they might have a real interest, intellectually in teaching you, because it's interesting for them too. And also interventional cardiology, like there are like hidden groups that do have experience. I'm sorry to interrupt you, Stephanie.
No, that's okay. We also utilized our PICU and ER divisions. But in addition to them, we utilized our interventional radiologists and our anesthesiologists for vascular access practice in areas of that. And we have a vascular access team that comes to the bedside and will place PIVs if you need it. So we actually utilize them for practice as well.
One other thing to think about is there are the PEDS-EM has ultrasound fellowships. And so there tends to be scanning shifts in the PEDS ER, in the PEDS and adult ER that they've invited us as neonatologists to be able to come and do some shifts with them. So just as another consideration for, as Jason mentioned, the adult side, adult and PEDS EM may have some opportunities there.
Great. Kind of related to that, we've talked a lot about collaborating with other departments or divisions. When you are collaborating with other departments or divisions, are you expected to protect their time in any way or reimburse them in some way?
That's not how collaboration works.
Yeah, they've been pretty generous in their time. Here at Emory, there's an EM, PEDS-EM that comes up twice a month and does scanning shifts with us in the NICU. So they've been very generous with their time. And when we worked with the PICU, we provided some structure with a REDCap database and some of the quality assurance that we could do together. So there's a little bit of shared ability there, but yeah, I agree with Alan. People are just very generous with their time and wanting to teach.
Another group I just thought of is the echo techs. Like you would not believe, once you try to do an echo and then you see the echo techs, that they can get any view and any patient at any time, even when they're screaming, like they are amazing. So if you can just look over their shoulder as they're doing their echoes, like they're an amazing, and they might they might be very busy, but at least you're seeing their technique. And if they're not so busy, you know, many of them are happy to teach you different things. And they're probably smarter than the cardiologist. Oh, did I say that? Sorry.
We've gotten a little bit of a question about the REDCap use. So for the different institutions that have used REDCap, do you need IRB approval to store practice images with MRN data?
No. It's behind a firewall. It's very well accepted. We do almost all of our QAs with it and everything else. I haven't asked the IRB that question, but nor will I ask the IRB that question. It's none of their business. We are tracking the number of scans that our team have performed, and we're doing it in a HIPAA compliant way.
So we did approach our IRB and they were actually fine with it. And we did it through as a QI initiative. So we had as a QI, so it's IRB exempt for the REDCap database. But you're right, Alan, they didn't care. So.
Yeah, I think probably most places you can collect the data for quality assurance purposes. If you want to do a study later on, you'll have to get IRB approval to go back and look at it and analyze it and publish it. But if, you know, prospective collection of it is for quality assurance.
Great, thank you. And May actually wrote in that they do a joint curriculum with PICU and PIM for their fellows, so that way they can offset the burden or lift to offset their time. So thanks for sharing. That's a really good idea to have that combined medical education curriculum.
Yeah, we've done that. We're doing that for next year's combined boot camp for our new starters in July. We also have a fellows college that we're going to do 1 half day per year for this as well. And we're setting up a POCUS elective curriculum for subspecialty fellows from all the subspecialties. And again, everybody ends up chiming in with whichever bits of help they've got. It's a very, very collaborative process. And again, most people that have been using POCUS want to help other people use POCUS because they've seen how impactful it is.
Yeah, we have a monthly meeting between radiology, NICU, PICU, and emergency medicine, where we share cases and have a short didactic session. It's been really valuable. I mean, one anecdote is, you know, you would think radiology would have no interest in it because they already know all this already, but it's not completely true. Like, they noticed that in point of care ultrasound, people were doing a lot of lung ultrasound, which I think traditionally radiology hasn't had much of an interest in. And so they realized, you know, we should really learn more about this. And so we kind of spurred them to learn more about a certain aspect of it also. So it's you know, everyone learns from it.
Great, thank you. And I know we're right at 5, but since we had that little bit of the tech glitch in the beginning, we'll ask a few more questions. For anyone who has to leave, please make sure that you fill out our survey that Rachel sent in through the chat. We would really appreciate any feedback going forward, particularly any questions or things that you want answered during our last webinar of the series. So our next question is, if someone is just getting started, getting POCUS in the unit, and they're still in training mode for diagnostic purposes for POCUS, do you typically have to get informed consent from parents?
We're doing practice scans, do you mean?
They say for diagnostic purposes, so I'm not sure if they're talking about maybe when they're doing diagnostic scans. So if you guys would speak both on the training or educational scans aspect, as well as if you're using it for diagnostic reasons.
My personal practice for this is that if I'm credentialed to do it and I want to do it, then I don't have to ask. If I'm proctoring somebody where the scan is clinically relevant, but I'm going to do the scan with them, then I don't have to ask. And if I'm doing it on a baby that clearly has nothing wrong with them and we're just trying to practice, I personally get verbal assent from the families. I don't get written consent from the families.
I would agree with that. At our institution, they're pretty prescriptive about it, that they do want you to get that verbal assent, like Alan was talking about, if you're using it just for training scans. But I would think if you're using it more so along the lines of like an adjunct to your physical exam, like say you do this on pretty much every baby that comes through your triage area, then I wouldn't think that you would necessarily need to. But I think in the context of a training study where it is not necessarily necessary to the baby's care, then yes, I would think that you would need to get at least verbal assent from the family.
Great, thank you. Can any of you guys talk about any competency tools that are available for POCUS? And if not, how are you assessing competency at your institutions?
I'm not aware of a competency tool. I showed the mini KEX that we do as our final stage of sign off, which I like. And then I think a robust QA process that we're going to talk about in the next webinar is the best we can do to ensure that people's scans are getting an extra pair of eyes on them to maintain quality.
Yeah, I would agree with that. I think the QA process, we have an Excel spreadsheet that kind of goes through here the things that you need to be able to see on your exam, and some of that is from what Alan's actually put together, I think, through the pediatric cardiology and some of their interpretation and acquisition. So it's really through that QA process that we do it. But I agree, I'd love to have some competencies set out and standardized. That would be great. But that's what we use for now.
Yeah, we do the same thing. Every Thursday we go over all our scans from the prior week, and one person's writing reports while the other person is sending feedback to the person who did the scan so that they can, you know, continually improve their technique. And we
Jason,
encourage everybody.
And we do every scan. How many scans is that?
It depends. I mean, it varies from week. It'll be 5 to 15, maybe.
Thanks.
And we've touched on this a little bit already, but maybe we can talk about it a little bit more since we did get a question about it. But how are you guys determining the number of scans? Are there any societies or other places that have a general guideline for saying like 20 scans for this, 25 scans for that? So can you guys just talk a little bit more about that?
I mean, I think, yes, there are other societies that might have some guidelines, but I don't really know of any for neonatology. And it was just interesting as Alan was going through his talk, talking about how many numbers that he requires for his trainees. And I know, Jason, you were talking about how many numbers you require. And I look back at what we require, and we require something completely different. And it's not even every year, it's every 2 years in order for maintenance of competency. So I really don't think that there is any kind of a standard out there, maybe yet, maybe ever, but.
I mean, I think the one that sticks out in my mind, I forget if it was the Society for Echocardiography published something. It was like 150 echoes, and it was just, it has to be a balance between what's actually doable and I don't know, there has to be some reasonable aspect of it, or no one is ever gonna do it, and no baby's ever gonna benefit from these tools and these skills. I don't know where our 25 came from. You know, it came from somebody else who'd done it ahead of us, but yeah, that's the document that I'm talking about. But 25 to me seems fairly reasonable. You know, it makes sure that somebody's committed to practicing and doing it, but not so much that it's a huge barrier and no one will ever jump over that barrier.
And I think Alan was really getting to that point too, when he was talking about trying to find the sweet spot between all those scans that he had different criteria for. But exactly what Jason said, trying to ensure that your trainees and your staff know what they're doing, but not making it overly burdensome so that they don't do it at all.
So this is the 2011 ASE statement, which I violently disagree with. They stated for the core level, that's basic targeted neonatal echo, you need to spend 4 to 6 months of dedicated training in a pediatric echo laboratory for the basic level, and you have to do 150 scans, and then you need to do another 150 scans supervised. And then after that, if you want to get the advanced level, you need to do another 200. But that's for people that are doing complex processes that are clearly echocardiography. and we can have an endless argument about what's POCUS and what's targeted neonatal echo and what's echo. I have deliberately kept our indications here extremely tight. Presence of a heart rate, presence of an effusion, a broad assessment of filling. I am not credentialed to assess PDA. I'm not credentialed to assess PPHN. I'm not credentialed to quantify SVC blood flow, any of those other things. I'm perfectly capable of doing all of those things, I promise. But it wasn't worth the fight, because I can get somebody to do those echo assessments for me at relatively short notice. And the turning point decision for me for an cardiac ultrasound is, am I giving volume or am I giving a pressor? And therefore, I just need to look at filling. But to suggest that any of us need to do 300 scans to be able to tell whether a child's urinary bladder is in retention or it's empty is not sensible.
I mean, if the person asking the question maybe you're referring to procedural stuff, you know, our nursing colleagues, our PIC nursing team has been sort of more rigorous about numbers, and I think they have new nurses who want to be part of the PIC team and do ultrasound guided PIC lines to observe 5 and then do 5 supervised, and then they can go ahead and do them on their own, which I think is also a reasonable number. But you know, I always encourage people, since as Alan said in his talk, people start off doing vascular, is I always tell people to start off doing regular lab draws, but with ultrasound guidance, right? Because there are a million lab draws every day for genetics or for whatever, where you need, you know, 4 mLs of blood, and it's not that easy. So first do that with the butterfly, and then you can go on to A lines and IVs and PIC lines. But you know, simulator, then blood draws, then the other stuff, I think, you know, and if you use the number 5 to observe, I think it's a good starting point for procedural applications.
Great, thanks guys. Okay, so we are going to wrap up. Oh, actually, May chimed in and said that she went to an adult ultrasound conference. This is kind of talking about the competency, and there were talks about OSCEs for POCUS. So that could be on the horizon for adults, and then will hopefully trickle down into pediatrics and neonates. So thank you everyone so much. Special thanks to our wonderful panel of experts. Thank you guys so much for joining. Thank you, Alan, for a wonderful talk. For everyone who registered, you will receive an email with a link to the recording of this webinar, and that email will also have a link to our survey that we, again, would love any feedback, comments on, so we can make sure that we continue to improve this for the future. All right, thanks guys. Have a great rest of your day.